Constipation is an extremely common problem affecting up to one-third of all children and is the reason for consultation in up to 5% of all pediatric healthcare visits. Constipation is defined as difficulty in passing stool for at least 1 month, with the majority of cases being classified as functional constipation. Functional constipation is a diagnosis of exclusion and should only be considered when other organic, medical, and surgical causes of constipation have been ruled out. Organic medical causes of constipation in children can be congenital or acquired and include cardiac and thyroid abnormalities, electrolyte abnormalities, most especially hyper and hypocalcemia, cerebral palsy, cystic fibrosis, milk protein allergies, delayed development, and even certain medications such as anticonvulsants. In the same way, organic surgical causes of constipation can be congenital or acquired and include anorectal malformations, Hirschsprung's disease, anal fissure, spinal cord abnormalities, colonic stenosis, and even colonic dysmotility disorders. When assessing a child with constipation, take a thorough history and perform a detailed physical examination. Children with underlying medical or surgical problems resulting in constipation will have signs and symptoms related to their underlying pathology. Specific red flags highlighting such underlying pathology include failure to pass meconium within the first 24 hours of life, constipation within the first year of life, children born to diabetic mothers, reliance on enemas to pass stool, failure to thrive, anal fissure or an abnormal anus, meningomyelocele or other obvious or occult spinal abnormalities, hypothyroidism, heart failure, developmental delay, and children on certain types of medications. Carefully assess all children with constipation for these underlying causes. If you suspect a child has an underlying medical or surgical pathology that manifests with constipation, seek expert opinion regarding further management. Always remember that breastfed children can experience infrequent stooling. As such, it is important to examine the patient as a whole. Infrequent and painless stooling in a healthy child that is growing well and with no obvious disorder does not require further investigation or treatment apart from reassurance and counseling of parents on appropriate danger signs and symptoms. Functional constipation is far more common than organic constipation and usually occurs in boys between the ages of 1 and 5 years. Functional constipation is the result of painful bowel movements resulting in voluntary stool holding. This voluntary stool holding results in the passage of large, hard stools, which in itself is painful, thus reinforcing the cycle of voluntary stool holding and perpetuating the cycle. According to the Rome 3 criteria, functional constipation is present when a child experiences at least 2 of the following criteria for at least 1 month: passing less than 3 stools per week, a history of painful or hard stools, 1 episode of fecal incontinence or soiling of underwear in children that are already toilet trained per week, history of large stools that clog the toilet, or the presence of a fecaloma or a large hard fecal mass. Soiling in children with functional constipation is a form of pseudo-incontinence due to rectal distension and diminished sensation, allowing for liquid stools to involuntarily leak from the anus. Additionally, children with functional constipation may present with urinary complications such as urinary tract infections and dysuria. Always be aware of the possibility of non-accidental injury in children with constipation. In most cases, children with functional constipation examine very well with no evidence of chronic disease. It is extremely important to examine all children with constipation thoroughly, starting with general examination and then moving to a more focused abdominal examination. Important danger signs on examination include anemia, low weight or height for age, abdominal distension or the presence of an abdominal mass, obvious spinal or neuromuscular abnormality, abnormal per-rectal examination including evidence of a fissure, an abnormally located anus, explosive release of stool on per-rectal examination, or even the presence of a presacral mass. Common biochemical and radiological investigations in children with constipation include thyroid function tests, serum calcium, magnesium, and phosphate levels, contrast enemas, rectal biopsy, and even advanced investigations like MRI of the spine and colonic manometry. This said, these tests should absolutely not be routine and should only be recommended by specialists in children with suspicion for an organic pathology or disease. In most cases of functional constipation, plain abdominal X-ray is sufficient to establish the presence of fecal loading with or without a fecaloma, to rule out other possible causes of the patient's symptoms, and to monitor response to treatment. Functional constipation is treated in 3 steps. First, through oral or rectal fecal disimpaction. Second, by the use of medication to maintain the passage of soft stools. And third, by dietary and lifestyle modification to prevent relapse. Oral disimpaction is often preferred to rectal disimpaction by patients as it is less invasive and painful. It is often achieved through the use of osmotic laxatives such as polyethylene glycol, lubricant mineral oils such as castor oil, and stimulants such as senna. Rectal disimpaction can be performed manually with rectal washouts of phosphate enemas in order to achieve results more quickly, though this is not as well tolerated. Remember that the use of phosphate enemas in children with renal failure is not recommended. Stool softeners, stimulant laxatives, and lubricant oils can be used in isolation or in combination to maintain the passage of soft stools once disimpaction is achieved. Sustained symptom relief often requires medication to be taken for as long as the duration of symptoms. So for instance, a child with a 9-month history of functional constipation will usually require up to 9 months of medical treatment in order to achieve complete resolution of symptoms. Dietary and lifestyle change is as important as any other aspect of management and includes increasing the amount of fluid intake, particularly juices with sorbitol, such as apple juice or water, and decreasing the amount of milk protein intake. Decreasing the intake of substances that worsen constipation, such as white bread, rice, pasta, red meat, and pap, and increasing the amount of fiber in the diet by increasing the amount of vegetables and fruits consumed. Finally, children should be habituated to pass stool by establishing a toileting diary that sets daily times for attempted stooling and records the timing and consistency of each stool. It is extremely important to involve parents in this process to help them to understand what is wrong, what is being done to address the problem, and to remind them to remain supportive and positive toward their child. Counsel parents to be patient and to continue with the treatment plan, as treatment requires a high level of commitment. There are surgical options for the management of functional constipation, but these should only be resorted to when all non-surgical options have failed and should be dictated by a specialist. Thank you.